I'm a surgeon, and this is about surgery, and I also do quite a lot of work in the area of mainly polyposis syndromes, but also Lynch syndrome, and there are lots of parallels. I just want to have a little recap about colorectal cancer in general, and then talk about surgery for colorectal cancer, or treatment of colorectal cancer, and then why I'm here today talking about this and why this topic comes up whenever you're talking about Lynch syndrome. Some of us have just been to the 2-yearly meeting of INSIGHT, which is the International Society for Hereditary Gastrointestinal Tumours, which is the sort of professional society that has an interest in this worldwide. And there was a talk on this in that, and virtually every time we meet, we talk about this, so it's very topical. So just let's remind ourselves about cancer, bowel cancer. So it starts at stage 1 in the lining of the bowel, localised to the lining of the bowel. Stage 0 is really a polyp, pretty malignant polyp. Then it invades through the lining of the bowel and is stage 1. Through the wall of the bowel, stage 2, but it's still where it is. And I tell patients that bowel cancer is a bit like a plant. It starts to grow, puts in its roots locally into the bowel wall, and then if you leave it long enough, through the bowel wall and through into neighbouring structures. And then stage 3, it throws off seedlings into either the bloodstream or the lymph, the tissue fluid circulation, and those settle elsewhere from the bowel. Those settle where that fluid gets filtered. So for the lymph fluid, it'll be in the closest lymph nodes. For the blood, it'll be usually in the liver or the lungs are the commonest places because they're filter areas. So stage 3, it's gone to lymph nodes, and the lymph nodes cluster around the artery. So you've got the artery taking the blood to a bit of your bowel, and the lymph channels are coming the other way. And that's what that little box there is showing you. And then stage 4 is when it's spread beyond that, beyond the lymph glands to liver, lungs, or anywhere else. Okay, so that's how colorectal cancer develops. And if you think about the sort of management pathway that most people go through, whether they have Lynch syndrome or not, first of all, your cancer is diagnosed, and that's usually with a colonoscopy or a limited flexible sigmoidoscopy, which is like a colonoscopy, it doesn't go the whole way around, and a biopsy. Because we need biopsy, we need to know that that it looks like cancer on the biopsy. Sometimes it's obvious that you can actually feel it because it's so low down. The doctor can put their finger in and feel it, and you don't sometimes even need a scope to take a biopsy. Sometimes it's diagnosed on imaging, on a scan. But first of all, you make the diagnosis, and then we always examine the whole of the large bowel. And we do that because quite a lot of people who have bowel cancer have other things in the bowel. They might have inflammation, they might have polyps that need to be precancerous polyps that we mustn't forget about and that need to be removed. They might have lots and lots and lots of polyps and make us think they have an inherited polyposis syndrome. They might actually just have a second cancer. That's more likely if you have Lynch syndrome, but anybody can have a second cancer, and about 1 in 25 people diagnosed with bowel cancer actually has a second one at the same time. And it's not really that surprising. If you think about it, bowel cancer is caused by exposing our gut to all the nice things in life: alcohol, red meat, being lazy, not taking too much exercise. Those are the risk factors. Well, if one bit of your gut has been exposed to that enough to get cancer, the whole of your gut has. So it's not surprising that a few people actually get more than one bowel cancer. So we always look at the whole of the large bowel, either with a colonoscopy or with a CT virtual colonoscopy. And we stage the cancer. We try to work out which of those stages I just showed you it's at. So we do a scan to check the liver and lungs, and to look around the actual tumour to see whether it's grown out from where it is into neighbouring areas. And if that's down in the pelvis, if it's actually a rectal cancer, CT is not very good because of all the bones in the pelvis. You get much better imaging with an MRI scan. So that's why people with rectal cancer get an MRI as part of their staging. So that gives us all of the information about the rest of the gut, well, about that cancer, about the rest of the gut, and about the rest of the body where cancer could have spread to. So you start off knowing all those things in order to plan treatments. Now, why do we do surgery for bowel cancer? You know, there are cancers that you don't do surgery for. Well, really the reason we do it is that the alternative treatments don't actually work. Although that's not entirely true. So radiotherapy, you can't give radiotherapy to the colon, or not really, because radiotherapy, it's not terribly accurate. You just shine radiation in a sort of area, it's all a bit blurry, and you irradiate neighbouring structures. And in the abdomen, you've actually got small bowel, big blood vessels, kidneys, other stuff that does not like having radiation. In the pelvis, it's a bit easier because the tumour is fixed. It doesn't move about. You know, if you've got cancer in your colon and you lie on your side, the whole thing just moves about sometimes. So actually targeting it can be quite difficult, whereas in the pelvis it's fixed and there's less other stuff around that's radiosensitive. So actually we do sometimes do radiotherapy, and the idea of radiotherapy in the rectum is to what we call downstage the tumour, so to make a bulky tumour shrink so it's easier to get out and you're more likely to remove it completely. But we now know that if you give a combination of chemotherapy and radiotherapy, it's more effective, and some people who have that with the aim of making the tumour smaller and easier to remove, in some people the whole thing disappears altogether. And we in the world of bowel cancer surgery now have a bit of a dilemma, because we now know, well, what are we going to do with it? And now what do we do? Do we now just plough on merrily and do our big operation that we were going to do before? Or can we not do it? How do we know that the tumour's really gone away completely, unless you take everything out and get the pathologist to tell you? But it seems a bit extreme to do a big operation just so the pathologist can tell you that there's nothing there. So we chew this over a lot in surgery because, you know, we're not quite sure, frankly, what to do with people who get what we call a complete response, complete clinical response, because you don't necessarily know it's complete. We're always concerned that it isn't, and it's a dilemma. But these treatments are getting better, and this may change. You know, we're getting better at very focused radiotherapy that doesn't irradiate lots of other things. And better chemotherapy, probably better targeted chemotherapy, and probably in the not too distant future being able to analyse tumours more accurately before you even start and know which ones are likely to respond to these treatments and which aren't. So actually it's going to get more complicated. But at the moment, fundamentally it's surgery. And I've also put mechanical issues there. We're simple soul surgeons, you know. Tumours block things. They block tubes, they block the bowel, they press on things like the bladder, and actually you need to take them away so they don't do that. So that's why we do surgery. The surgery also gives you some of the staging. I've said we scan people, but it actually gives you some of the staging. So how do you know how far through the bowel wall it's gone? Well, you can do scans, you can do ultrasound scans, you can do MRI scans, but actually the most accurate thing to do is to give the tumour and the bowel to the pathologist and they'll tell you. So actually that gives you the most accurate staging. And the lymph nodes, again, this is a thing we wrestle with. We would like to be able to know from a scan if lymph nodes are involved or not. But scanning, it's not accurate enough. As we are at the moment today, it is not accurate enough. So until we actually take those lymph nodes out, we can't know for sure. And of course, that's useful information, because what knowing the lymph node status and the T stage can help you with is knowing how likely this tumour is to already have spread, how much people are going to benefit from having chemotherapy, how intensive the follow-up needs to be. And unless you have that information, you're slightly blind. So unless you've done the operation and taken it out and know, you don't quite know what you're dealing with. And that's another thing that freaks us out a little bit about these people who respond to the radiotherapy and chemotherapy. Because if you don't actually know what's happened to their lymph nodes or anything really, and we don't like that. We don't like uncertainty as surgeons. Neoadjuvant therapy is what you give afterwards, what you give before. So this is the treating the rectum with radiotherapy or chemotherapy to try and shrink the tumour and make it easier to remove, but it sometimes actually treats it completely. Colon, I put question mark because we're moving towards that. Adjuvant therapy is when you think you've cured the tumour with surgery, but you know, because you know that there were some lymph node deposits, you know that there is a chance, perhaps even as much as a 50% chance, that that person actually has little tiny cells that have seeded in the liver and lungs. You can't see them yet, but those are the things that will grow and make metastases, or what we call recurrence. It's not really recurrence, it's something that's already there, it's just you can't see it. If we think that somebody has a significant risk of that because we've done pathology on what you've taken out, then you give them chemotherapy. It's a bit like using weed killer. You've taken your weed out of the path, and you know that it might have seeded. There are some sort of open seed pods. So you think, well, I can't see any little weed seedlings on my path, but I know that this weed has seeded, so I'm going to just do a quick spray with weed killer to stop anything little that's there. That's what adjuvant chemotherapy is. It's not trying to treat tumour you know is there. It's taking people who you think are at risk of having something teeny weeny and wiping it out. So that is what we do, and we are trying to remove the whole tumour with clear margins. Yeah? Don't leave anything behind because it'll just grow. We're trying to remove the lymph nodes that drain that tumour, so that we can see if there are lymph node deposits in there, because if there are, you might want to give somebody adjuvant chemotherapy. Also, you're actually removing them, which might be a good thing. And we want, obviously, to minimise complications, and we want to have the best outcome in terms of quality of life and function. So that's how often you go to the toilet, whether you have a stoma or you go the normal way, all of that kind of stuff. So that's what we are trying to do. And normally we do it by removing the segment of bowel where the cancer is. So this is come up, the screen's a little bit small, but let me sort of try and show you. What you've got here is the colon and the rectum. When I was a trainee surgeon, when I very first started, I could not understand really why you had to do these operations, why you didn't just take the cancer out. The reason is it's to do with the lymph nodes and the blood supply. If you're going to take a piece of bowel out, you've got to have blood supply to the two ends at either side that you can then join together. And you've also got to be able to move them so that they will go together. And in order to achieve that, that's why we do these, what we call segmental resections. That's how this surgery has evolved. So if your cancer is up in this area up here, you remove that and do this join. You remove that segment. If your cancer is there, you remove that segment and join. If your cancer is down in the rectum, you remove the rectum and take the colon above down to the anus. So you're like that. Right-sided, if you have your cancer here, take out the right colon, the cecum and ascending colon, and join the small bowel on up here. So that's that operation, that's a right hemicolectomy. So all of these are what we call segmental colectomy. So they're taking the tumour and its blood supply. And of course, increasingly we're doing this with laparoscopic surgery, keyhole surgery, so it's less invasive. You've got to make a big enough cut to get the tumour and a piece of bowel out, but basically you can do it with much less invasiveness. That's what the sort of instruments and so on look on the inside. And all operations that we do have complications. Every anaesthetic has complications. It's pretty safe. I say to most of my patients that unless they've got some really major health issues, for most people the anaesthetic is safer than the journey to the hospital. But we all know whenever we get in a car or on a Boeing 737 MAX that it is not, life is not without risks, but it's pretty safe. Everybody is at risk of getting blood clots in their legs that can whiz up to their lungs. They get infections and wounds and chest. But all of those are very dealable with nowadays. There's specific risks of surgery. The biggest problem with bowel surgery is leakage from joints. what we call an anastomotic leak. So you take out your segment of bowel, join the ends together, and then there is a leak, and that's a major complication, which obsesses and terrorises all colorectal surgeons. Now, when I talk to patients about it, I think people think that it's like, the plumber. If you had the plumber in to mend your pipes, and 4 days later you had a puddle on the floor, you would not use that plumber again, okay? But it really is. We're not that bad. It's really not like that. It's about healing. If you imagine cutting your arm and you go down to A&E and they put some whatever it's called nowadays, ED, or whatever they call it, they put stitches in, okay? They put the skin together to let it heal. You then go home and you're meant to heal up. And sometimes you might find that a little area gets infected or just opens up, or the skin dies back a little bit and you get a slightly uglier scar. Okay? That's not about the person who stitched you up. That's about the blood supply or the injury or bruising or whatever to that bit of skin. And if it's the skin, it doesn't really matter. It just takes a bit longer to heal. Just doesn't look so nice afterwards. But if that happens in the bowel, then you actually get a hole in the bowel and poo leaks inside the tummy, and that makes you obviously quite unwell. So the surgeons do actually join the bits of bowel together quite nicely, and all we're actually doing is putting them together so that they can then heal, holding them together. So don't blame your surgeon if you have a leak. It's just one of those awful things that happens, and we do everything we can to minimise it, but it just happens. In the pelvis, you can get damage to pelvic nerves that make your bits not work very well, and we try and avoid that, obviously, but it is a risk. And later on, anybody who's had an operation can have hernias and a destruction because of adhesions, because of scarring from surgery. Some people, if we're worried about anastomotic leakage, we sometimes do this. We sometimes create a loop ileostomy upstream. So basically what you do is create a temporary ileostomy above the join so that poo doesn't go past the join until you're sure it's healed. And this is, some people have this temporary stoma for 3 months or so after surgery. Basically what you do is you just bring out a knuckle of bowel like this, open it up on one side and flip it back so that you end up with the poo coming out of this little nozzly bit, and then if you were to go down here you get to your join, but it stops the poo going down. But it's nice, it's quite easy to put this back together. You just cut around here, free it up, and then just join it back how it should have been. So after surgery, this is for generally speaking, we do colonoscopy every 3 to 5 years because somebody who's had bowel cancer is at more risk of getting another one than somebody who's never had bowel cancer, because they've done the things in life or their bowel has been exposed to the things that's called their first cancer, and of course the rest of their bowel has been exposed to the same thing. Okay, and they may have minor inherited risks as well. So we do colonoscopy every 3 to 5 years, and probably about 1 in 20 of those people will get another bowel cancer. They can get local recurrence at the join. Sometimes cells can get sort of, cancer cells like, they're a bit like, they are like seedlings, they're little seeds. They like nice soil, and sort of inflammatory tissue or scars or wounds is fertile soil. And if there's a cancer cell knocking around that's kind of fallen off the tumour and it lands where you make the join or in a wound, it can grow. So we always look at the join, because sometimes you can get recurrence on the join, and we look at that with colonoscopy as well. And as I say, metachronous, what metachronous just means through time. We talk about synchronous tumours, which are at the same time as one tumour. You've got synchronously some others. Metachronous means through time, so develop later. We also do CT scanning to just look and see whether those tiny little seedlings we couldn't see at the beginning, that we didn't know whether they were there or not, whether there are actually little seedlings in lungs, liver and elsewhere that grow, that then need treatment. So we look for them, and they are curable potentially if we find them. They're curable with surgery to remove liver or bits of liver, radiofrequency ablation to zap them, some chemotherapy. There are ways to treat these, so it's not necessarily the disaster it used to be if metastases grow. And some people do CEA blood tests, but I remain deeply sceptical about the evidence to support that. So, So that's just what we do for bowel cancer. What about Lynch syndrome? Well, let's just remind ourselves, you all know that one of the problems with Lynch syndrome is noticing it, realising that somebody has Lynch syndrome. The other patients I deal with polyposis, it's really easy. You have to be blind to, as a doctor, to miss most polyposis patients. There are some that are a bit confusing and a bit subtle, but you do a colonoscopy and they've got 500 polyps. Really, how hard is that? That's just a no-brainer. Lynch is much, much more difficult because there's nothing to find until somebody has cancer. And the things that make our antennae twitch are people or families that have cancer young and have these clusters of sites of cancer, so bowel, endometrial, urothelial, and those get us twitching. The family history I'm not really going to talk about because I'm sure you all know about this, and actually it's being sort of superseded and it's not really that good. The most important thing now with NICE is looking at tumour characteristics, and that gives you an entree. If somebody has a cancer and you find the characteristics, that gives you an opportunity to see whether they have Lynch syndrome or not, and then to help them and their family. Okay. And we do know that if you do that, you're basically looking to find these tumours that are mismatch repair deficient, and about a quarter of them will turn out to be from somebody with Lynch syndrome, and about 3/4 will turn out actually to be very similar biologically, but due to switching off of the MLH1 gene. And I don't think we know quite why that happens. Ian may know, but he hasn't told me. If we could find out why that happens, we could maybe stop it. But anyway, so we know that the actual tumours in Lynch syndrome are actually different from the vast majority of classical bowel cancers, which are these. They're different and they have a slightly better prognosis.
Your cursor is not on the screen, so we don't know what.
Okay, sorry. Okay, fine. All right. So the green ones, thank you for pointing that out. The green ones are the bog standard bowel cancers, and we know that the blue Lynch syndrome ones are different. They have a better prognosis, stage for stage. They seem to grow more quickly. There are certain different behaviours, and as we've just been hearing, they respond to immunotherapy in a way that the standard cancers don't. So you're actually dealing in Lynch syndrome with a slightly different disease. So if you go back to all the reasoning I gave you about what we do for standard bowel cancer, you've got to go through all of that and change it a bit. Change lots of bits of it, because it's all based on assumptions for standard bowel cancer, which might be a bit different for Lynch syndrome. So what are these differences? Well, Lynch syndrome is about 4 or 5%, 4% or so of all bowel cancer, so it's a minority. If you have Lynch syndrome, your lifetime risk of cancer is much higher, but probably lower than we thought in the past. It's going to be more likely to be on the right side of the bowel than on the left. The cure rate is higher. You do need to have colonoscopies more often in the future because the cancers appear to grow more quickly. And the chances of you getting another cancer in the bowel are much higher than the average person. I'm going to talk a bit about how much higher, because I think we've overestimated that.
Excuse me, why is the right side occurrences more than the left?
I don't think people know. I think in Lynch syndrome it's much more just directly related to the surface area of the bowel. Whereas in non-Lynch related cancer, left side is more common, probably because there is a different bacteria and different environment there that are causing more genetic damage. Whereas in Lynch syndrome, actually it seems to be just directly proportional to the surface area, and therefore you almost need to look at it the other way around. Lynch syndrome is just directly proportional to surface, and non-Lynch is much more common on the left, probably because you're getting more mutations on the left because of the environment. So I just want to go down into a little bit of detail about a few of these things in a second or two. So we need to accept that people with Lynch syndrome have a higher risk of colorectal cancer. We'll talk a little bit much in a minute about how high. But that does mean that they're more likely to have a synchronous cancer. So if somebody with Lynch syndrome has one bowel cancer, you need to look very carefully for another one and make sure you don't miss it. They're also more likely to have a further cancer in the future in remaining bowel, and the colonoscopies need to be more frequent. Of course, there are also higher risks of other cancers, endometrial and ovarian particularly, that you can actually think about at the time and do something about. The prognosis is different. Prognosis is better. So you actually might have a higher threshold for giving adjuvant chemotherapy in somebody with Lynch syndrome because it's more likely that you've cured them with surgery. But when you do need to give them some therapy, you need to probably give them something a bit different, as we've heard. So it's really important that everybody involved in caring for these patients, particularly the oncologist, knows that they are dealing with somebody with Lynch syndrome with cancer. And then, of course, it's really important to make sure that the family, you're not just focusing on this person with Lynch syndrome and cancer, but that the rest of the family is having appropriate management. So, the operation. What's different about the operation? The basic staging is the same. You just have to be a bit alert for other cancers. Just, when you're looking at the CT scan, or the MRI of the pelvis, just say, are we sure this woman hasn't got an ovarian or an endometrial cancer? Are we sure we haven't missed a synchronous bowel cancer? Now, the operation. If you are having an operation and you're a woman, actually having a hysterectomy and oophorectomy, in terms of the surgery, I'm not talking about the impact on you, I'm talking about the operation. It's actually very easy to do it. It doesn't take very long. It does not add very much at all to the complications or length of that operation. So it is straightforward to do it, but obviously it's a huge decision for that individual woman, and it's something that needs to be thought about very carefully. And particularly thinking about people's age, need for hormone replacement, and all of those things. And I think it's very important that a gynecologist is on board with the decision making. I've come across a few women who've just been told that they're going to have a hysterectomy at the same time as their surgery for their bowel cancer. And nobody sat down with them and talked to them about HRT, pros and cons, what they can expect, what actually risk it is that they're avoiding by having a hysterectomy. And I think it's really important that we think about that and don't just think about it as kind of an extra bit that the bowel surgeon's going to do. The real crux, though, is the more extensive bowel surgery. So the idea of this is, if we remove a bit more than our standard segment of bowel, in theory, you'd say, well, we're going to reduce the risk of this person getting bowel cancer in future. That's got to be good, hasn't it? And if you do that, you might mean that they don't need, if you take out all of their large bowel, they won't need colonoscopies anymore. Well, is that good? Well, maybe. And, they won't need any further surgery. Well, that's good too, isn't it? Maybe. But that's where this comes from. And it comes partly from polyposis. Now, polyposis, FAP, is nothing like as common as Lynch syndrome. But the risk of bowel cancer is it's nearly 100%. Basically, pretty much everybody with FAP will get bowel cancer by the age of 45. All of them. And what they have is hundreds and hundreds and hundreds of polyps. And the only way you can stop them getting cancer is to remove the bowel before they get cancer. So we do these operations where we remove large bowel in teenagers. And it's really effective. They have an almost normal lifespan after that's done. And sometimes people like that with FAP are not diagnosed until they turn up with cancer. And then when they turn up with cancer, again, it's a complete no-brainer. You take away all the rest of usually the colon, sometimes the colon and rectum, with the polyps. And it is a no-brainer. But surgeons have sort of somehow got that into their head and kind of moved it across to Lynch syndrome, and I think that's where some of this started from. So what are we talking about doing? So I showed you those little diagrams that you now know you couldn't see me pointing at, but we were talking about taking out, for example, for a tumour here, just taking out this section, okay, and joining the small bowel up to there. So what we're talking about instead is actually taking out either the whole of the colon and joining the small bowel to the rectum, or taking out actually the whole of the large bowel and using small bowel to reconstruct it. Let me show you over here for these people over here. So what we're talking about is instead of maybe taking out just 1/4 of this, or a bit over there, we're talking about taking out the whole colon, joining the small bowel to the rectum, or taking out the whole large bowel and either having an ileostomy or reconstructing with the small bowel, which is a big and complicated operation that is very far from perfect. So that's what the suggestion is. So, why? Well, the idea is that you prevent death from cancer. From this cancer, won't make any difference, because it's no better to take a load of healthy bowel than just to do the segmental thing. Future cancers, it's what we call secondary prophylaxis, preventing future cancer by taking away the thing the cancer would grow in. Well, there is actually no evidence at all that it does that it prevents death. Okay, I'll show you some of the flawed evidence in a moment. It doesn't do that. It does reduce the rate or the risk of getting a second bowel cancer, but it doesn't reduce mortality. Or at least there's no evidence that it does, which is slightly different. The reduced need for endoscopic surveillance, which is unpleasant, has some risks and is costly. Well, if you leave the rectum, you've still got to look at that every 2 years, at least. So you do need to have something done. Yes, if you remove the whole large bowel, you don't need colonoscopies. And I think there's possibly an argument if you were going, for example, on a mission to Mars and you couldn't have colonoscopies, it might be quite sensible to have your large bowel out before you went if you had Lynch syndrome. Or if you had a large cancer, if you had a cancer. But I mean, otherwise, we in this country do have good access to colonoscopy. Again, it's an argument perhaps for people who live somewhere where they don't. There are a lot of the world you have to either can't get a colonoscopy or have to pay more than you will ever earn in your lifetime to get one. So I think we need to think about the context of where people are. And it reduces the need for repeated surgery. Okay, so if you look at the literature and you look at people, you compare people who had Lynch syndrome and cancer, and you compare people who have had just a segmental colectomy, just the standard surgery, with people who've had the extended surgery, and you look at the risk of getting another bowel cancer, and it's about, there's a sort of diamondy blob down at the bottom here. And that's what you add all the studies together, it's called a meta-analysis, and basically you are 5 times more likely to get another cancer in the studies that have been done to date if you have bowel cancer and Lynch syndrome and you just have a segmental colectomy, compared with somebody who has a bigger bit of bowel removed. Okay, that's what the studies show. However, we have this situation. The goalposts have moved a lot. So the first thing to say is that we're all talking about Lynch syndrome. There's all sorts of controversy about whether we should even call it Lynch syndrome anymore, because actually if you have a pathogenic variant in a mismatch repair gene, you're completely fine. You don't have a syndrome. You don't have. You're a completely normal, healthy person. All it does is increase your risk of cancer, and when you get cancer, you get a slightly different cancer. Does that need to be called a disease? Anyway. But it's not one thing either, because your risks of getting cancer vary according to which gene is involved and your gender. So this is some information from the prospective Lynch syndrome database, which Tony Seppälä from Finland has been very involved with. And if you look at the blue line, if you look at the left, the blue line is MLH1 mutation carriers, and that's a 50% cancer risk by the age of 70. That's lower than we've been previously told. That's probably because in the past we had what we call ascertainment bias, and we only actually discovered people who actually had bad disease. It's sort of or aggressive disease. It's a sort of slightly self-fulfilling prophecy. You're not going to detect people who don't get cancer because they don't get cancer. So how are you going to find them? It's only when you actually look for people genetically, see that they have a mutation, and then watch what happens and discover that actually they don't get cancer nearly as often as you thought they would. So the risk is lower than we've been taught, and it really depends. So if you look at the green line, which is MSH6, actually that's really it's not really that high, that risk at all, actually. And then the graph on the right is gynecological cancers, I think. I haven't got my glasses on, I can't actually see it. I think, that's gynecological cancers, isn't it? So if you actually have a PMS2 mutation, actually your risk of bowel cancer is really low. But if you're a woman, you've got a bit of a significant risk of gynae cancers. So maybe those people don't need anything at all. And actually, what should we be calling that? Okay, the next bit of I'm not going to steal John's thunder because he's here at the back and he's going to talk about aspirin. But massive movement of goalposts, if it's all true. CAP2 told us that aspirin halves the risk of getting bowel cancer. So that means it should halve the risk of getting your second bowel cancer if you've had a first. So automatically, just by taking aspirin, that diamond I showed you that said you're 5 times more likely to get another bowel cancer than somebody who's had a segmental resection, it should be 2.5 times. You can automatically take that little diamond and move it to half. So every risk that's been talked about in the literature before this, you can just halve it, probably. So, and the other thing that we don't really think about is the outcome. So surgeons say, you can take this much bowel, or that much bowel, that much bowel. So when you, as the patient, are saying, right, well, what should I do? Well, I'm going to take aspirin now because I've been diagnosed. Now, which mutation do I have? Which gene is involved? And, you might make a decision. I think probably if you have an MLH1 mutation, you're at the highest risk of getting another cancer. If you have an MSH6 mutation, you're probably relatively quite low risk of getting a second cancer. And then you're going to halve that with your aspirin. So you can perhaps start to get a handle on your individual risk. The problem is your surgeon is still working on historical data from 15 years ago. What about the outcome? So you're saying, okay, that's the risk of me maybe getting another cancer in the future, but this bigger surgery you're trying to sell me, that can't be just completely fine, surely. Well, why wouldn't we just do it on everybody? And basically, the more bowel that you have removed, the more you poo. Defecatory frequency is going to be higher, and it's about 2 extra poos a day, on average, for somebody who has an extended compared with a segmental resection. And if you have your whole large bowel removed, you actually have a much higher pooing frequency of 5 times a day and once a night as an average. Now, if you start off as somebody who poos a lot, you're going to poo a lot more. And if you start off as somebody who has a bit of trouble and doesn't poo very often, it actually might help you. So you have to actually think about your pooing. If you're a woman who's had lots of vaginal deliveries, you may actually have weak sphincters. Some women with a completely normal intact bowel have a bit of trouble, have to rush to the loo, some have accidents. If you're already a bit like that, if you then have a great big chunk of bowel removed, that is going to be a lot worse. So it's a very individualised thing. Quality of life, we all want, quality of life information where it's a sort of holy, everything should be measured with quality of life, which is true. The trouble is the measures that we have of quality of life are not perfect. And I'll give you an example of that. I know that everybody in here has thought about bowels. A lot of people will have had bowel surgery. Nobody wants to have a stoma, do they? Anybody given the choice of having a stoma or not having a stoma, all other things being equal, wouldn't want to have a colostomy or an ileostomy. And anybody with a colostomy or ileostomy, I think if they were told we could just get rid of this and it would all be fine, would like to get rid of it. I don't know, does anybody disagree with that? But if you look at quality of life measurements, there is no difference between people with a stoma and without a stoma. And that's because the quality of life measurements are probably measuring the wrong thing. They're measuring people's resilience. People can be very optimistic. People can get on with their lives and manage really well. You know, they ask questions about, you know, what can you do? What do you know, how do you feel in the morning? Do you feel, you know, happy, sad, very sad? Or what? They ask those sorts of things. And it doesn't get to the crux of would you rather not have this thing. It just is saying that these people are coping equally well on the measures that we're measuring. But it isn't actually, there's something that quality of life measures as we use them are blunt instruments. And I think don't take quality of life measures as gospel, because they are flawed. They're probably the best thing we've got at the moment, but there are things that they can't measure, which is something about preference, which we're trying to find ways of measuring. So quality of life, there's actually no difference on the studies that have been done, but I have given you a health warning about that. Let's just look at some studies. I'm going to struggle here because I'm just going to get my glasses and I can't even read this. So I'm not going to go through this in detail, but I just want you to sort of see where the problem is with the literature. Where my glasses are. Right, I'm going to have to squint. So, this was a study looking at segmental versus extended colectomy, differences in morbidity, function and quality of life. And it says...
Do you want me to read it out?
Yeah, if you can read it, that would be really good.
Okay. Measurable compromises in long-term bowel function and quality of life were observed after extended versus segmental resections. The relative differences in patient-related outcomes should be deliberated against the clinical benefits of extended resection for the individual patient.
Yeah, so that's academic speak for we don't know. Okay, this one is particular for Lynch syndrome, and I think this is bigger. I can read this. It says, although functional outcome is worse after extended resection than after partial colectomy, generic quality of life does not differ. That's generic quality of life measurements don't differ, not quality of life probably. After the two types of surgery, when discussing the options for surgery with the patient, all advantages and disadvantages of both procedures, including quality of life and functional outcome, should be discussed. That also is we don't really know, but talk to the patient. And this one, over to you, Ian, I can't read that.
Okay. The optimal surgical approach in the management of HNPCC, call that Lynch, remains unclear. More adenomas and cancers occur after segmental colectomy than after total colectomy, but there certainly is no evidence to suggest that more radical surgery leads to improved survival.
Yep. So there you go.
That comes from Des.
Yeah. Anyway, they're all the same. So my approach is that it's an individual decision, that you go through the pros and cons with the patient, and the pros and cons for that patient, depending on their gender, age, mutation, or the gene, other factors like their pre-existing bowel habit, what their bowel function is like now. You need to take into account their access to endoscopy, which in the UK is probably a bit of a irrelevance, but globally is relevant. How acceptable endoscopy is. There are some people in whom endoscopy is impossible, or they really can't tolerate it, in which case you might actually need to figure that in. Where the tumour is, because that does make a difference. If it's in the rectum and you're talking about removing the whole of the large bowel, that's a pretty big deal. Other issues, continence, their job. You know, actually some people can do their job much better with a stoma than with high bowel frequency, or with I've got a patient who's a commercial airline pilot and actually did need to have all of his large bowel removed, and we were talking about doing a reconstruction, an internal reconstruction, which is what most people want. But I couldn't predict his bowel function, and he might need to go 5 times a day, and he can't be coming into the, Heathrow and have to nip to the loo. It just would not be compatible with what his job, and what was the most important thing to him was his job and going on with that lifestyle. So he chose to have a stoma for that reason. You have to go through these things with people. So what I find difficult is things in surgical guidelines which are there. Words like extended colectomy is preferred. That is wrong, I think. I think it could be considered and should be discussed. But things that say it is it is the default option, okay? And there are terms like that in existing guidelines. And it's based on flawed evidence and a lack of understanding of the way things have changed. So extended surgery is not the default option, but it's something that you can consider on an individual basis. And it's important in women to at least consider hysterectomy, offer it, discuss it, again, in the context of that woman's individual risk, but make sure that the issues, the gynecological issues, are discussed with a gynecologist, not a surgeon just saying, oh, I'll whip this out while I'm there, because that happens too. It's also really important that oncologists are aware of the diagnosis, that high quality endoscopy is done for the remaining large bowel afterwards, that patients have aspirin, and I used to say that they go onto the CAP3 study, but it's now closed, but they have aspirin, and John will tell us how much aspirin and what to do. And it's really important to make sure that the rest of the family have been properly managed. So if anybody has any questions, I'm delighted to answer them.